I'm delighted to be here on behalf of FAAFP. FAAFP is the Fertility Appreciation Collaborative to Teach the Science. And this is an organization that I co-founded with another family physician, Dr. Bob Motley. And it was basically in response to my experience having never heard the term natural family planning or fertility awareness or learning anything about these methods until I was a first-year family medicine resident. But I'll talk about that a little bit more tomorrow. We are under the umbrella of the Family Medicine Education Consortium, which is a secular medical education organization based in the Northeast. We have no relevant financial disclosures. I wish we did. We could really use some more funding. But to date, we are really able to do this work in large part because of very generous individuals that donate to our work, and the fact that I married a saint who allowed me to quit my job in 2012, ostensibly to help raise our 3 children, but also to grow this organization. So anyway, oops, wrong direction. So this is our roadmap for today. We're going to go over some objectives. Our goal is to introduce, and I realize many of you may already be trained in fertility awareness or natural family planning. Many of you are medical professionals. Some of this may be a bit redundant in terms of the science and the physiology, but it's important, we think, for everybody to be on the same playing field. So we're going to go over the scientific basis. Dr. Daggs will then introduce the variety of modern fertility awareness-based methods that are available. We'll talk about how these methods can be used to achieve pregnancy as well, and then how you can help women and couples choose which method may be best for them. So our objectives, our goal is to define what are natural or fertility awareness-based methods. What, for many of you, the term fertility awareness-based methods may be brand new or maybe somewhat an uncomfortable term, but we're going to talk about what the differences and similarities are between the terms. Again, go over the science and discuss their variety of applications and how they work, and then the benefits and challenges, including the use of apps. So just full disclosure, that article in Cosmo was just a highlight of the apps review, but I thought probably got more readership here than I did with the Journal of the American Board of Family Medicine, no offense to them, but anyway. So key terms. So the term fertility awareness-based methods is relatively new. It really highlights the use of these methods using daily observations of specific signs that a woman's body produces based on hormonal changes. By charting these specific signs, whether it's cervical fluid, basal body temperature, urinary hormone measurements, a woman can identify her potential days of fertility. This term emphasizes an understanding of one's fertility, and it also highlights that these are methods that are more than just methods of family planning. I'm a firm believer that we should be teaching all women that are of reproductive age about how their body works to develop a healthy appreciation of their fertility. The term natural family planning is probably much more familiar, and it emphasizes that these are based on natural science of fertility, specifically excludes the use of barriers or chemicals, and it highlights and emphasizes that couples share responsibility for family planning by modifying their behaviors depending on their family planning goals, or as we learn in Humani Vitae, if they've got serious reasons to postpone. Now, at FAAFP, we will use these terms interchangeably. We do tend to use the term fertility awareness-based methods preferentially because we want to emphasize not only the family planning method aspects of it, but also the health applications. FAAFP has also introduced the term fertility awareness combined, and why is that? Many in the secular world will use the term fertility awareness method, or FAM. The FAM community, in general, that typically refers to the symptothermal method with or without the use of barriers such as condoms. I think that's a little misleading because when couples are using barrier methods in combination with a fertility awareness-based method, they're typically only using barriers during their fertile window. And so if the method fails, it's not the fertility awareness-based method has failed. They knew that they were fertile. It is the barrier method. And I think so we like to use the term fertility awareness combined when discussing that in particular. It is important to note that almost all of the studies to date on fertility awareness-based methods, how they're used, their effectiveness, have been done when couples actually abstain from sexual relations during the fertile window, as is recommended. And so the data that Dr. Stanford and I will be talking about next will primarily highlight that. It is also important to note that if couples do use another method when they're fertile, they can probably expect lower effectiveness rates than what's typically quoted, right? So for example, in medicine, we learned that the condom has an 82% typical use effectiveness rate. Well, that was when they evaluated the use of the condom throughout the entire cycle. If you're using the condom during phase 3 when you're not fertile, it's not the condom that's working, the woman simply is not fertile. So if you're only using barriers during the fertile window, the likelihood of failure is even higher. So why is this important? I mean, obviously, for those of us here, this is really what Pope Paul VI called us to do in terms of sharing this information. But I would argue this information is relevant to our entire world, our entire country, our entire medical community. And that's why as an organization, FAAFPs really, our goal is to share the science. Because my belief is we need to give this information to everyone. I like to say nobody's ovaries are Catholic, so this information shouldn't be limited to Catholics. This should be made available to everyone. And why is that? Well, women are interested. There was a study that Dr. Stanford had done back in 1999, and another one that Dr. Leonard did in 2006, both of which that show when women are given information about natural family planning and told what it is, more than half express interest in learning these methods to either avoid or achieve pregnancy. These methods are safe. These are the only methods of family planning classified by the World Health Organization or recognized by the World Health Organization as having no medical side effects. That's really important. They're effective, as we'll discuss, Dr. Stanford and I will discuss in the next presentation. They're affordable. Really, the biggest cost to these methods is time. It's an investment in learning. Many of these methods, once you learn how to use the method, there are no ongoing costs. Some do have some, but if you look at it over the lifespan of the woman's reproductive life, it's much more affordable than conventional forms of birth control. There are no drugs or insertable devices. It amazes me to think that there are so many women that willingly accept the insertion of a metal or a plastic device into their uterus and will walk around with that for 5 or 10 years, and that doesn't seem to faze them. And I think to myself, how many men would actually allow that? So they're environmentally friendly, and I point this out because this is where we see the greatest interest. When I go around the country to give talks at medical schools and at hospitals, the people that are coming are not the Catholics. The people that are coming are the people that are concerned about the environment and the hormones in our water, and so it's very interesting. These methods are educational. They teach a woman the way her body is designed to function normally, right? Conventional forms of birth control, actually, the pill is the most widely prescribed medication given to a healthy individual to create a diseased state. And yet many women think of the pill as a vitamin. You know, they're like, I take it every day. It's like a vitamin. I'm like, it is not a vitamin. So it's amazing. But with fertility awareness-based methods, women and men learn how our fertility, our reproduction is designed to function. And it's empowering. All of a sudden, women, you know, as young as 12 and 13 are no longer freaked out by that monthly discharge that they get. I mean, I can tell you as a physician how many patients I've seen come in month after month. You know, I've got this infection again, I've got this discharge again. I had a couple ones who came to me because they were struggling to conceive. She was 27, he was 30. I mean, they were young. So they shouldn't really have had fertility problems. And the wife was very upset. This was, you know, very emotional for her because her husband had a child from a previous relationship. So she was really bearing the guilt and thinking that it was something wrong with her body. And that was worsened by the fact that she described to me this monthly infection she got. She got this discharge every month, and she said, whenever I get that, I just don't have sex with my husband because I don't want to give him whatever it is that I have. And I thought to myself, it can't be this easy. You know, and I did a workup, and it was completely normal, and I said to her, I'm like, humor me. The next time you have that discharge, just have sex with your husband. The only thing you will give him, I can guarantee you, hopefully, is a baby. And they came back 2 months later pregnant. I mean, for a year she had been struggling because she just didn't know. So this can be very, very empowering. So, what are modern fertility awareness-based methods not? So when I give this talk, I'll often ask people, you know, when you hear the term NFP or fertility awareness, what do you think of? A lot of people look at me with blank stares. They're like, I've never heard the term, you know. But the most common thing, if people do say something, is, well, that's the rhythm method, right? FAAFPs actually surveyed family medicine women's health directors, the faculty members that are responsible for training future family doctors about women's health. And we asked them specifically, what methods of fertility awareness are you most familiar with? The #1 method was the rhythm method. And I'm thinking to myself, this is a horror as a family physician. We pride ourselves on evidence-based methods. And that's not to say that the rhythm method is not a good method. At the time, it was developed in the 1930s. It was based on the best science. You know, at the time, we weren't doing randomized clinical trials or prospective cohort trials. So the method itself was never studied, but it was based on good science. And if anybody ever did a study, it probably would show that it could be very effective. But the difference between the rhythm method based in the 1930s and modern methods is the applicability and the data that it uses. So I like to tell people, I mean, think about the rhythm method like the first telephone. I mean, how many of you still have a telephone that looks like that, right? I mean, at the time, the telephone was a great invention. But modern fertility awareness-based methods are like our modern smartphone. How many of you just use your smartphone just to make phone calls? It's your everything. Just like modern fertility awareness-based methods are more than just family planning methods. They can be used to help a woman know when she's going to get her period, to be able to better manage her PMS symptoms, to help couples who are trying to conceive. So the difference really between modern fertility awareness-based methods and the rhythm method is the data. So with the rhythm method, women would basically track the length of their previous cycles, and based on the shortest and longest length of their cycles in the last 6 months, they would use a formula to try to calculate and predict their fertility for the coming month. So you're using retrospective data to predict future fertility. With modern fertility awareness-based methods, women are using data in real time. They're using daily observations of their cervical fluid, measurements of basal body temperature, urinary hormone measurements to identify their likelihood of fertility in that moment. So it's using real-time data. Cervical fluid is the sign that's probably used throughout the majority of the methods, and it's amazing. For those of you that have never heard of the name, Professor Eric Odeblad, the man is a genius. He should have won a Nobel Prize. He's one of my idols, and I would love to get to meet him one day. He has basically been studying the cervix and cervical fluid for more than a half a century. He started his work in the 1950s, and he originally discovered two types of cervical fluid, type E, which was produced under the influence of estrogen, and type G, produced under the influence of progesterone. And you can see here, this actually isn't working, but you can see here, under the influence of estrogen, cervical fluid forms channels. It's basically swim lanes for the sperm to find their way through the cervix into the uterus in search of the egg. On the other hand, under the influence of progesterone, it produces type G mucus, which basically creates like a mesh-like network to prevent the penetration of sperm. In further research, Dr. Odeblad discovered there were subtypes of type E, types L, S, and P, which probably a little bit more detail than you all want to know, but it's fascinating, the role of cervical fluid. And it basically forms what we refer to as a biological valve. Under the influence of estrogenic type fluid, the likelihood of fertility is higher on certain days, and it's because of the effect of the fluid. And when it's present in the most amount, when it's thinnest, when the leukocytes are low, the white blood cells, the sperm survival is high. Okay, are you with me so far? This is like the most science I think you'll probably get, basic science at this conference. This is a really important slide. Again, for those of you that are trained in this method, it's very, very familiar, but I want everybody to understand the basic science. So let me orient you. So if you look at the top line, it says ovarian histology. That shows the changes that occur in the ovary throughout the course of the cycle. The second line shows hormones. That shows what's changing in terms of the woman's hormones. Next, we have the endometrium. That's the changes in the lining of the uterus. And at the bottom, you can see the changes in the cervix, okay? So by convention, we typically mark the beginning of the woman's cycle as the first day of her period. Now, when I speak to younger audiences, I often ask them, why do you think we call the period the period? What is a period? Period marks the end, right? So technically, the period marks the end of the previous cycle, but because it's the most recognizable sign, we use that by convention to mark the beginning of the period. But in the beginning, when she's menstruating, her hormone levels are low. During the course of her cycle, the follicle-stimulating hormone begins to stimulate the follicles in the ovary. The follicles in the ovary begin to stimulate the production of estrogen or estradiol, and the estradiol begins to stimulate the development of the uterine lining and begins to stimulate the development of what we call fertile type cervical fluid, fluid that is thin, watery, slippery. As the estradiol levels, you can see there, as the estradiol levels rise, once they reach a a threshold level and begin to drop, that actually triggers the spike of the luteinizing hormone. That's the green hormone. So you can see it's very low. We get a spike. The LH hormone is what triggers ovulation. You can see in the top line the egg is being released. And this is typically when the fertile cervical fluid is the most watery in amount. After ovulation has occurred, and again, ovulation is a sign of health. If a woman's hormones are not functioning normally, she's not going to ovulate. So ovulation is very important as a sign of health. Once the woman ovulates, the remnant corpus luteum forms, and that begins to produce progesterone. Progesterone is the black hormone that you can see there. The progesterone causes a number of changes. It causes the lining of the uterus to change to a more secretory lining, and it changes the cervical fluid. Once the progesterone levels begin to drop, if a woman has not conceived, if the pregnancy hasn't taken over progesterone production, then that's a sign to the woman's body that there is no pregnancy. The progesterone levels will change the cervical mucus and get into a thick mucus, but as they begin to drop, it signals that pregnancy hasn't occurred. The woman sheds the uterine lining and it starts over again. Okay? Are we good? Any questions on that? This is probably really important. And again, for some of you, I hope you're not having horrible PTSD flashbacks to Repro 101 in medical school. The rise in progesterone is also what causes that rise in basal body temperature. And I like to put this here so you can actually see directly the curve. Wow, I'm at halftime, so I need to move it. One important thing to note, most people think the normal cycle is 28 days in length. Non-medicated cycles, only 10% of them are actually 28 days. The majority are, the normal ranges from 21 to 35 days. So this is just to conclude by showing that what is happening internally in the woman's body can be reflected externally through the signs that she can see with the rise in estrogen causing the changes in cervical fluid. Ovulation occurs, you get the peak type in the urinary hormones, and it's that last day of fertile type mucus that is clear, stretchy, or lubricative. As the corpus luteum secretes progesterone, you get the rise in basal body temperature and change in the mucus to a thicker type mucus. And as the corpus luteum atrophies, progesterone drops, you get the menstrual bleed, which is probably the most recognizable sign. So this is an example of a normal female cycle. And again, it's really just designed to show you how what the woman charts is a direct reflection of the internal changes that she is experiencing. So when estrogen is low, she's dry. As estrogen is rising, she'll notice the fluid. Once ovulation has occurred, progesterone rises, she again notes dryness and a rise in basal body temperature. Fertility awareness-based methods, as I said, really can serve as the fifth vital sign. And we teach a course that basically explains how a woman can learn to chart her cycle and how as a medical professional you can use that information to better understand what is happening. Now, as a physician, about a decade ago, we were learning how pain is the fifth vital sign, but I would argue that nobody needs pain to survive. But we do, as a species, need healthy fertility. So it really can serve as a vital sign. Charting can work for anyone. I'm a big believer we need to be teaching our adolescents. I have a 10-year-old daughter, and she already has a basic understanding because it shows what's happening in the body. It can work for individuals, for couples, and again, specifically with adolescents, there are a number of programs, if you're not familiar with Teen Star, developed by Dr. Hannah Klaus, who also was here at SLU. I am a trained Teen Star educator, as is Allison. Teen Fem, which is a program associated with fertility education and medical management, and then the Catholic Sisterhood of Women, which Allison can speak to as well. These are all programs designed to teach adolescent girls how to understand and appreciate their fertility. Faith. Oh, I knew I needed to give you something. There you go.
So there's a whole range of women's health issues that can be addressed using fertility awareness-based methods, from PCOS or polycystic ovary syndrome, premenstrual syndrome, dysmenorrhea, irregular cycles, fertility disorders, postpartum depression, and recurrent miscarriages. Common approaches that medicine now teaches, and in women's health, internists, family medicine doctors, OB/GYN professionals, really we've been given one main tool to use, which is oral contraceptives, to treat those several conditions as well as things like antidepressants, and in the context of fertility or fertility disorders, assisted reproductive technologies. And we've really kind of somewhat abandoned an understanding of normal ovulation and then abnormal ovulation in order to really get at root causes and treat the cause and not just mask the symptoms. Things like PMS in a woman tracking her cycle, understanding when to anticipate the post-ovulatory window. When she understands when that time is coming, we can target treatment to when she needs it and not just give her medication she's going to use all cycle long for one particular window in her cycle. These methods are an excellent tool for both achieving and avoiding pregnancy in a natural way. So it's really important to understand those key components of fertilization, and the three powerful components are pretty obvious: sperm, the egg or ovum, and then fertile cervical fluid, which equals a baby. That fertile cervical fluid is necessary for the sperm to be maintained within the reproductive tract, to get to the target, and to be in a state where they're able to fertilize the egg. Without this type of fluid, the sperm are pretty much DOA within the vagina, and with the fluid, it improves the ability for a woman to conceive. So simple to understand, but very powerful. So it takes two. I tell my patients, no one is fertile alone. You need to have a partner in order to achieve a pregnancy. And so it takes both the man and the woman to contribute. So healthy men are pretty much fertile every day. Healthy women are mostly infertile and only have a window of fertility in their cycle. In fact, once ovulation occurs, that egg only survives for about 12 to 24 hours. Fertile cervical fluid is critical for the effective transport, and there's a narrow time frame in which a couple can conceive. This fertile window typically lasts only about 3 to 6 days in each cycle, and so over the course of a year, there's only about 70 to 80 fertile days for a couple together, or about 20% of the time. So together, couples can learn when their fertile window is, and then to modify their behavior for their particular family planning desire. So this is from a study published in the New England Journal of Medicine in 1995, simple, very seminal study by Wilcox and colleagues that demonstrated the potential days of fertility within a cycle. So it corroborated timing of cycle intimacy with hormonal and ultrasound indicators of ovulation. So we know that the fertile window, based on those indicators, can vary in some couples to less than a day to more than 5 days, with the fertile phase frequently lasting about 3 days. Therefore, a man and a woman are only potentially fertile for about 6 days in the cycle, and this is a really short period of time. Although rare, sperm can live in a woman's cervical crypts up to 5 days, and fertilization can occur up to 12 to 24 hours post-ovulatory. So there's a maximum of 6 days of fertility. The highest likelihood of conceiving in a cycle is actually with intimacy, in this study, 1 to 2 days prior to ovulation, and then the likelihood of pregnancy decreases to 0 within 24 hours after ovulation. So now that we've discussed the components of fertility, we're going to see how the anatomy and the physiology work together for a conception to occur. So around ovulation, the cervix produces fertile fluid. The sperm survive, travel through the uterus to reach the ovum. The eggs are produced, matured in the ovary, and released during ovulation into the fallopian tube. And when egg and sperm meet, a new genetically unique individual is created. And the developing embryo travels down the fallopian tube to nestle into the endometrium, where the baby will continue to grow for up to 9 months till a new baby is born. So in addition to being effective for pregnancy avoidance, we know that these methods actually reduce the time to achieve pregnancy. With no method of timing or targeted intimacy, couples having random acts of intercourse, 85% of those are going to achieve pregnancy within a year. However, We know that couples who have awareness of the fertile window and are using timed intercourse or fertility-focused intercourse are much more likely to conceive much more quickly. This is from a study by Nath and colleagues looking at a symptothermal method. 80% of couples conceived within 6 months. Similar research has been done using ovulation methods with the Creighton model with Hilders and colleagues, showing very similar rates, 75 to 80% conception rates, couples of normal fertility within 6 months. So what about the other 15 to 20% who don't conceive and are subfertile or infertile? We know that we can use fertility awareness and the information we get from charting to really help couples conceive. Dr. Hilders and his colleagues have really revolutionized the use of fertility awareness as in its medical applications to help couples through medical and surgical protocols to achieve pregnancy at rates that are similar to, or actually better than assisted reproductive technologies, and tend to increase the lifetime pregnancy rate for those women and those couples as well. So how does this work? This is an example of a woman who is having secondary infertility. She had a normal full-term first pregnancy, and this chart shows us that looks like she has pretty, what we call regular cycles, 29 days. So she's going to present her OB/GYN, they're going to be like, what's the problem? You conceive before, you have regular cycles, there shouldn't be any issue, or you're unexplained infertility. If we take a closer look, we can see that this woman has average peak days pretty late in her cycle, between days 19 to 21, 22, and a short post-ovulatory window in her cycle. So in traditional gynecology, we're taught in evaluating a woman's cycle, the efficacy of her ovulation if she's ovulating at all, get a progesterone level on cycle day 21 because everyone ovulates on day 14 and everyone has 28-day cycles. Or there's kind of really broad generalizations that are used. And so certainly in this patient, if a progesterone level was checked, it might not have been positive. She might not have even ovulated yet. And that's not really a good way to evaluate her cycle. But using her chart, a much more cogent and relevant evaluation can be done. So the top part of this shows this woman's progesterone levels that are happening in the second half of her cycle, post-ovulatory. Her levels are in the red, and the normal curve is above in black with a standard deviation above and below. So even shortly after ovulation, this woman has poor progesterone levels that are below the normal curve. By less than a week out from ovulation, her levels have dropped to practically 0, and she's probably already starting menses. The critical thing about this is this woman wants to conceive again, and we know that conception occurs around the time of ovulation, but implantation occurs about 6 to 11 days after ovulation if she's conceived, and this poor embryo is just not going to make it in that lining without progesterone support. So this fertility awareness-based method, Creighton model specifically, gives us the means to diagnose and then formulate a cogent treatment for this woman, which in this case is progesterone support using progesterone itself, or maybe using something like HCG to stimulate the ovary, or even supporting ovulation to have a better corpus luteum effect. So let's get into the fertility awareness-based methods themselves. So this is just, a correlate of the woman's chart that shows her peak day and that short luteal phase, which correlates directly with the blood work that's been done. So going into the methods themselves, we're going to discuss 5 main types of methods: cervical fluid methods, symptothermal methods, symptohormonal methods, the standard days method, which is an algorithmic method, and lactational amenorrhea. These methods encompass a broad array of how a woman can observe and track her cycle and the data that can be used to then predict fertility. Above our orange arrow are those methods that have data and scientific basis and have been published in the literature to be shown to be effective. And below the line are methods that are also available that really rest on their predecessors in the delivery of the methods from the data that came before. So you can see there's a lot of variety of methods available for couples and even available for medical professionals to teach couples and to really tailor to what that couple may need. And there's also been 3 systems that have made a particular effort to use this information in a way to direct medical evaluation and treatment. NAPRO technology, which encompasses Creighton model and fertility care, is really the most well-developed and I think has absolutely the most trained professionals both in the United States and worldwide, and has an excellent model for service delivery. But other less known medical models include fertility education and medical management, as well as some protocols with the Marquette model. And I think more is better. We can work together. We can make this just more available to couples. And I think also to recognize in service delivery is women and couples are coming to us with a spectrum of knowledge. Sometimes they've been taught and have used a method for years. Sometimes they're self-taught. They're looking for the information. They really need help. And we need to be open as service providers, however we're trained, to avail them of our knowledge and service. So cervical fluid methods, 3 evidence-based methods: Billings ovulation, Creighton model, and the 2-day method. Family Americas and FEM rest on the data that has come from Billings ovulation method mostly. The key characteristics is the observation and the awareness of cervical sensations, the knowledge of fertile and infertile discharges, and these methods can be used to both achieve and avoid pregnancy. However, the 2-day method does not necessarily identify when ovulation occurs, but Creighton model and Billings actually are much better at characterizing and consistently predicting ovulation. And these, of course, can be used for both avoidance and achieving pregnancy. Billings ovulation method is really the first modern fertility awareness-based method developed by John and Evelyn Billings in Australia. It is based on the presence of cervical fluid at the vulva and the awareness of the sensation. At the end of the day, the woman records her most fertile sign observed using her own words and uses a system of stamps and descriptions to identify fertility in the cycle. And this has very excellent effectiveness rates with correct use. 1%, one pregnancy per 100 woman years, and with typical use, 10.5 pregnancies per 100 women years. So with its typical use, it's really comparable to other user-directed contraceptives, such as condom or the pill, for the purpose of avoiding pregnancy. This is a sample of a Billings chart that just shows how the woman is noting different parts of her cycle, her bleeding, her vulvar sensation, and allows the woman to determine when she's fertile and when she's not fertile. So the opening of the fertility window is that change from dryness to dampness. As that sensation continues to be moist, the close of the fertile window is then noted by the change back again from wetness and slipperiness to dryness again, which is on day 15 here. That mucus change comes from ovulation and the presence of progesterone, which dries up the mucus. And the fertile window, we know, closes at peak +3. And the reason this is beyond the peak day is that we know that that peak day is indicative of ovulation within 2 days. Post-peak could be up to 48 hours after the last day of mucus, and then that egg can survive up to 24 hours afterward, which gives us our count of 3 and the close of the fertile window 3 days post the last day of peak type mucus. Creighton model also observes for cervical fluid, but uses a systematic approach where the woman learns a mnemonic to remember how to observe her mucus of soft, sensation, observation, finger testing. This was developed by Dr. Hilders and his colleagues, initially starting right here in St. Louis, and then further refined in Omaha. The Creighton model also uses a standardized and universal vaginal discharge recording system, which is very helpful for the medical providers who do NAPRO technology, because a chart can be very easily and objectively evaluated. For Creighton model, similar to Billings, the last day of the fertility is the peak day, which is the last day of anything that's clear, stretchy, or lubricative, also followed by that count of 3. With perfect use or correct use, also very effective, up to 0.5 pregnancies per 100 women years. With typical use, the Creighton model studies really looked at more so the intentionality of the couple, and that's where these methods are very different from contraceptives. And so a couple's intention can really change on a cycle by cycle basis versus looking at life tables over a year. And the Creighton model also led to the development of natural procreative technology. Because of this standardized and universal approach, it allowed the medical providers to really observe certain charting patterns in women who had pathologies of the reproductive system. And then the charting led to a very systematic and cogent way to evaluate and then treat medically with the use of medical NAPRO technology as well as surgical NAPRO technology to treat a whole variety of gynecologic health problems. So moving on to the last mucus-based method, the 2-day method. This is the most simple of the mucus-based methods. It was developed by Georgetown University's Institute for Reproductive Health, my alma mater. And this was part of a global effort to really mainstream fertility awareness-based methods and to provide something that was easy to teach, particularly in the developing world where there was limited resources for family planning in general. The user checks each day whether she does or does not see mucus. That's all. She doesn't quantify or characterize it qualitatively. If she sees something, she notes it. This is an easy method to be taught by the provider using the RH protocols. It can be taught in a 20-minute visit. It doesn't specifically identify a fertile window, so it's less informative than Billings and Creighton model, but it's still an accurate way to identify potential days of fertility and to be used for family planning, particularly pregnancy avoidance. With correct use, there's 3.5 pregnancies per 100 women years, and with typical use, about 14 per 100 women years. Moving on to the next category, symptothermal and symptohormonal methods. These use a cross-check along with the cervical mucus method, the cervical mucus. The symptothermal methods, most commonly available in the United States, SymptoPro, couple-to-couple league, as well as Sensiplan. Symptohormonal is Marguerite model. So as I said, cervical secretions are also observed as well as a cross-check, either temperature or a fertility monitor that looks at hormone metabolites in the urine, and can be also used as a means to achieve or avoid pregnancy. These help couples understand the opening of the fertile window as well as the closing of the fertile window. With symptothermal methods, there's observation of multiple symptoms, cervical fluid to identify the opening of the fertile window, and then basal body temperature and change of the fluid to identify the end of the fertile window. This cross-check for some couples is really important for them to have confidence in the family planning method they're using, particularly for avoidance. These also have excellent efficacy rates with less than 1% per 100 women years pregnancy rate for correct use, and in typical use up to about 2% unintended pregnancy rate. Reading a symptothermal chart. This is where a woman is tracking on top her basal body temperature, and on the bottom part her mucus sensations, as well as some softer signs of cervical observation, opening, closing, texture of the cervix. Phase 1 is the infertile part of the cycle where the woman is observing mostly dryness. As she enters phase 2, she marks the change in her cervical fluids, and her temperature is also noted to be low. As her discharges are changing and her basal body temperature is rising and the cervical fluid has become dry and has stopped, she enters phase 3, which is once again infertile. Symptohormonal methods, most notably Marguerite model, uses an electronic hormonal monitor, the Clear Plan Easy monitor, to check daily metabolic metabolites of of estradiol as well as LH, and also uses cervical fluid. Optionally, the patient can assess basal body temperature. This can be taught in a 15-20 minute visit in the office, and the patient can also self-teach online as well as record her charting online. This also has very efficacious, correct, and typical use rates. For the typical use, using the monitor alone, there was a 7 unintended pregnancies were seen per 100 women years, and with monitor and mucus, about 14 pregnancies per 100 women years. This is an example of a Marquette model chart that's available online. And both the mucus recordings have a corollary with the monitor recordings, low, high, and peak. High fertility begins when the monitor detects rising estrogen metabolites in the urine and the mucus is also becoming thin and watery. Peak fertility is noted when the monitor detects the LH surge and shows 3 bars to the patient, and when the mucus has a much more slippery raw egg white quality. And then the fertility window closes when the monitor changes to low and the mucus resolves. A final coming to our last 2 of the methods, standard days methods, is a standardized algorithm of fixed days of fertility, and it's applicable to women with regular cycles, 26 to 32 days. And it identifies the same fertile days for every woman. And you might think that's kind of a narrow window of cycles, but actually that 26 to 32 day range does consistently encompass or represent about 75 to 90% of cycles, so it can be suitable for the majority of women. The World Health Organization considers this a modern method of fertility awareness because it uses an understanding of reproductive biology, a standardized, precise protocol for correct use, and has been tested by appropriately designed studies. Even with its typical use, it's more effective than barriers, say the condom, with 12 pregnancy per 100 women years comparable, and better than the 18% failure rate of condoms. Lactational amenorrhea can be applied to the woman who's postpartum and is breastfeeding, who has not had a return of menses since the birth of her child, who is breastfeeding fully, meaning not giving any solid or other supplements with formula, and if her infant is less than 6 months old. These effectiveness rates are also very high, less than 2% per 100 women years for unintended pregnancy rates. And of course, breastfeeding has numerous benefits for both mothers and babies and should be strongly supported. However, due to a variety of factors, this data we may see earlier return, particularly in women in more developed societies who are more likely to be working outside the home and may not be able to fully and completely breastfeed. Okay, we're moving on.
I've got this one. Which is the bottom button that advances? Okay, thank you. So now we're going to move on to evaluating FABMs, and is this a good thing, and how is it a good thing? So Dr. Duane and Dr. Daggs have already touched on the advantages of using FABMs. So of course they're medically safe, they're very effective, there are no side effects. Things like breast cancer and blood clots and heart attack, stroke, those are some of the risks of using hormonal contraceptives. Well, with FABMs, there are no risks that are associated with that. It teaches women what is healthy and normal. In my experience with the Billings method and teaching adolescents, I can't tell you how many women think discharge and they think something negative, that it's something bad, that I have some sort of infection, that I need to, I need some sort of fluconazole, the antifungal, because I have a yeast infection. And so and when I teach, I try to, take back the vocabulary and this negative emotional connotation to the word discharge and really think about the positive aspect of a healthy vaginal fluid. And so just really helping them, the women that I teach, to sort of look at their healthy fluid as a good and a beautiful thing. And so I use that word a lot, that this is a beautiful and a good thing. And the young women that I teach, they get a little squirrely too, because they're like, oh my gosh, this just disgusting. And I tell them, I said, the men who are educated in this area and know what the fluid means, they like it. And they get surprised. And I said, it's a natural biological thing. Actually, the way we smell, our pheromones, they change when we are fertile. Ask a man who's living with a naturally cycling woman. He will know when she's fertile. And so the girls, the young ones, are like, okay, well, maybe. I don't know. I'm not sure I believe you, but I think I'll listen for a little while. So this empowerment that we have through education, where I think as part of fallen nature, we look at our bodies kind of like, just bodily functions. And so this empowerment through education helps us to receive and this gift that is our bodies. And so by understanding natural biological processes and seeing them through the eyes and through the lens of as a gift that we have, it empowers us to accept the reality of our biology and see it as a gift rather than something to transcend out of. I think in this time and place that we live in, people want to transcend out of their body, that, my body is actually not who I am. I'm really just, a brain in a jar. And so as Catholics, we have this beautiful idea of a sacramental kind of idea that we are a body, that we are embodied spirits, that my body actually is the art, right? The visible sign of who I am on the inside. And so as we educate women and men about the beauty of the body, we have a particular way of doing that because we're Catholic and we have this sacramental understanding of reality. So for couples, it improves their communication. I know Dr. Manhart just published a study lately about the benefits of FABMs in communication and even sexual satisfaction that is very high in couples who use fertility awareness-based methods, that it improves communication, there are minimal costs. And I say all the time, I was at the Women's March, I marched with the Students for Life, and it was difficult for me to see that many women marching for the right to kill their children. But as I was there, and I was happy that they were able to express their freedom of speech, I was there for the same reason. But what I see is that our society says that pregnancy is a woman's issue, that this is a woman's issue. And I'm like, no, this is a couple's issue. I tell a joke all the time that the 6 eggs that became my kids would never have become my children had I not been married and intimate with my husband. Thank goodness we were. I love all of my children. They're the best gifts I've ever received from God. But my eggs would have come and gone, right? I'm like a chicken. I'm going to lay an egg whether there's a rooster in a hen house, right? So this is a couple's issue. This is not a woman's issue. This is really between men and women together, and communication and cooperation together. So this is family planning for an entire life. The chart that I look at, my husband said just the other day, he said, the chart, Allison, is really just a symbol of a relationship between a man and a woman. I said, that's true. It's like a sacrament. It's like the sign, the physical sign that I get to look at, and I'm invited into this conversation, and I don't take that lightly, and I know that it's a tremendous amount of trust that a couple places on me to be able to walk with them through that learning process. So in addressing some concerns from the Pocket Guide to Managing Contraception by Zeman, so he and his colleagues in this guide say that, that people with irregular absent cycles can't use these methods. Infections are going to affect the mucus, and then they talk about as sexually transmitted infections. So of course with irregular absent cycles, that's a problem. And what is the normal the protocol for that? The pill, right? She has irregular absent cycles, let's put her on the pill. There's a reason why she has an irregular or an absent cycle. And all that beautiful slide with all that science on it, when a woman gets on a hormonal contraceptive, none of that happens. It halts that process. So whatever is causing her irregular bleeding, her absent menses, is going untreated, right? So amenorrhea is actually one of the diagnostic criteria for anorexia nervosa. We might be working with a girl who has an eating disorder, and we're going to put her on a pill, and rather than treat her for this underlying problem of her eating disorder. Infections affect mucus. Yes, they do. Of course, with a yeast infection, there is going to be a discharge. But women who are charting their cycles know what's healthy and normal, and they know what's not. So if there is a change in her mucus, she's going to know, oh, this is different. I probably need to go to the doctor. She's going to know that faster and more quickly and with more certainty than a woman who does not know what is healthy and normal. Sexually transmitted infections, there are lots of contraceptives that don't do anything. Actually, some data suggests that women on oral contraceptives are at higher risk for chlamydia, and women who have DEPO are at a higher risk for HIV, even when controlling for condom usage. So that whole argument that it doesn't protect against STIs, well, a lot of the other ones don't either. The only one that does are condoms, right? And those are, 18% failure rate. So you want to, compare and make some valid comparisons there. So there's the abstinence issue. Read Dr. Manhart's study, and you'll see that the abstinence issue is not that big of an issue. It is, but it's not at the same time. Couples who are working together and using these methods are very satisfied with their amount of sexual activity between them. It's unforgiving. Yes, we're 6 for 6, me and my husband. Every time we participate in the fertile window, I get pregnant. So yes, but the thing is that we choose that. And for a couple who knows when they're fertile, they're choosing that. Whether or not they're practicing the method with perfect use, they know that pregnancy is possible. My firstborn son is one of those choices. I knew I was still potentially fertile. I was close to the end. My temperature hadn't shifted yet. I was like, I still could get pregnant, but it'll be all right. And you know what? It was. David is the most perfect, wonderful son, and I cannot imagine my life without my oldest son, David, in it. He's made me a better person in every way. All of my kids have. It takes discipline, communication, and commitment. This was seen as a negative in this little book. I would call those things positive. That for long-term relationships, we do want to have discipline, communication, and commitment to one another. So I also teach fertility awareness to teens. And so I'm not so prideful to think that my way and our way that we do it is the only way. I know there's lots of ways to teach this to teens. So, but there should be some components of a really good program. A good program is more than one meeting. I can't tell you how many women who have tried to tell this to other women, like the women want to know this, but it's like a pony show. It's like a dog and pony show. It's like a one and done, but we can't do that. That actually leaves those women wanting because it takes some time to learn the cycle. So a good program has to be more than just a one and done kind of thing. There has to be relative content that's both biological and ontological, and I'm going to talk about that in just a second. And the third thing is that there needs to be some sort of personal encounter. As Christians, we know that it takes a personal encounter with Christ to transform who we are. And that's true in our interpersonal relationships as well. It's so easy to dog somebody online and really, just give them the riot act, but then you meet them in person, it's kind of like, oh, well, now I'm not real sure I can say all of that ugly stuff as with such force as I did, when it was anonymous, right? So that personal encounter helps us to become better people. As iron sharpens iron, right? And so that personal encounter changes us, transforms us in certain ways. So that's part of a good component of teaching fertility awareness to teens. So more than one meeting, like I said, fertility awareness takes time. It's a time of self-discovery. In the charting process, automatically women think that they're doing it wrong. 99% of them, they're like, I must be doing this wrong. No, you're not. No, you're not. Even though we're changing some of the wording and changing some of the symbols, doesn't mean you did it wrong. It's the process, right? Trust the process. The younger women might need longer. I know my 15-year-olds and 16-year-olds, they kind of struggle with the whole idea of wetness and cervical fluid, and they're not real sure. And at that age, menarche has just happened. And so some of that irregularity can be normal for them. And so it just takes them some time to figure that out and to discover that on their own. Repetition aids in retention. And then not all women are going to fit nicely into that scientific box. Man, I wish we did. But I can't tell you how many times when I talk to a woman, I'm like, you know what, this is going to happen. And she's like, wait, hold my... I'll show you what's going to happen, right? So when you tell a woman what she's going to do, it's kind of like trying to give a cat a bath. It's like, and no, not going to do that, right? So we don't fit into this scientific box. The range of normal is very wide, and that's why it takes some time for every woman to learn what is normal for her. So what is the problem with teaching just the biology alone? So we want to try to separate, the biology from maybe our ideologies or our religious beliefs and our religious convictions. Well, the thing is that, again, we're not just bodies walking around, right? We have our mind, we have our will, we have our emotions. We have to reach the entire person. And so whether this is taught in a religious setting or in a secular setting, there is some underlying principle that guides the teacher. What is that? And the teacher or whoever creates a way to teach adolescents has to really figure out what are our philosophical foundations. Is it a religious? Is it a secular? Is it what's healthy? What leads to health and happiness? What is that foundation from where we're coming from? So that personal encounter is with the teacher and with the self. So that the student is encountering her own self or his own self, and they are encountering the teacher. And that's where that transformation takes place. Again, the teacher is guided by some principle. The best teachers are guiding their students to self-discovery, right? So I heard this quote one time. I thought it was great. A good leader makes you believe in them, but a great leader makes you believe in yourself. And that is always my goal whenever I'm teaching to anyone, is I want my students to be empowered in their own self and believe that their body is good, that their body is healthy, that fertility is something that we don't have to be afraid of and fight, but is a gift to be received. So what influences sexual decision making? This is another element that we need to be thinking about when teaching teens, right? In the media, in the movies, in Hollywood, in magazines, does this promote sexual decision making that is going to lead to health and happiness? On Facebook, I keep getting these ads for Grey's Anatomy. And so the doctors in this show are certainly not standards of moral character. They're jumping in and out of bed with one another all the time. And none of them ever get an STI. They don't get pregnant. Or maybe they do. I don't know. I don't watch this show. I mean, maybe they did deal with a pregnancy and an abortion. I'm sure maybe now that I'm saying that, they probably did do that on that show. But what Hollywood puts up with us, puts before us what the magazines, Cosmo, and some of those very secular, they put this idea that there are no consequences to sex. Just whoever, whenever, whatever, just be safe. Use a condom, use a contraceptive, and there are no consequences. But that's just not true. Just from the purely biological truth, that's not true. Sexually transmitted infections are skyrocketing. We are in a health crisis. There's a statistic that I put up whenever I'm teaching adolescents, and by far the most infected group is age 15 to 24. That's my son. Right? My son is 15 years old. I'm terrified for him. And a lot of these kids don't really even know that they have infections, right? So, and that can lead to sterility later on in life. And it's like, I had this infection, I didn't even know. So there's a crisis going on because of what we've been placing before our kids and before our young people as normal, healthy, good things that's going to lead to health and happiness. So with this whole idea with what's placed before us, we know that we have lots of apps. There's tons of technology that we can use to help us with this with fertility awareness-based methods. But there's so many of them, and there's not a lot of science that backs them up, right? So there's over 1,000 apps on smartphones, and it is like I have my Fitbit, right? So this is tracking my steps, my heart rate, all that. After apps like this, fertility apps are the second most downloaded on the smartphones. So women are interested in this, but most of them are period trackers alone. They don't really do anything except put a little calendar up there and track your period. So Dr. Duane did a FAAFP study in 2015 that did a robust study on these apps. So at that time, there were 95 of these on the market, and so they automatically got rid of half of them because in the fine print it said do not use to prevent pregnancy, or it's not based on any science. It's just, oh, here's our app. It's really cute and pink and has flowers. Use it, right? And so half of those went away. So of those, they excluded more than half of those. So of those, they reviewed 40 of them, and they came up with their top list of which apps were actually the best that were based on evidence-based, fertility awareness-based methods science. And so they have their top ones. And so there are two types of apps that are out there. There are some that will predict periods, fertile windows, and then there are some that won't predict. And so they're broken down in that way. And if you are interested in that, I think Dr. Duane has a bunch of copies of those. So is there a best method? There's all these methods. So the answer is no, not really. The best method is the one that works best for each couple. I have charted every single method of NFP except for Marquette. And now that I'm sitting up here, I'm like, I should probably buy a clear blue fertility monitor just because I think it would be cool to say that I have charted every single method of NFP. And, because the basal body temperature shift did not work for me after I had kids. Because you know what? I wasn't ever sleeping. and you have to sleep for like 4 hours in a row and take it around the same time. I'm like, who has time for that? Nobody got time for that. So I stopped using the thermometer after I had kids. So we have to consider what a person's needs, where they are, the characteristics of the methods, the availability of teachers. This one's huge. The only reason I'm a Billings teacher is because when I got trained, that was the one that was promoted in my diocese. I was charting symptothermal, but I didn't want to be that person that came in there and was like, well, I chart symptothermal method, and that's the one that I need you to temp. I'm like, no, what is the one that is promoted here? It's Billings, great, go send me to be Billings trained. But I know enough about all the methods that when I teach couples, I can speak educatedly on every single one of them. And I'm never offended if what I'm teaching them is not working for them. It's like, well, let me find you what will work for you. Is it symptothermal? Is it Marquette? Is it Family of the Americas? Is it even a calendar method? Those can be pretty effective for women with very regular cycles, and some women, that's what they want, and they should have that. Basically, in conclusion, that fertility awareness can be used for any stage of life, it's truly methods for all ages, from menarche until menopause. A woman can find a method that's going to fit for her. So hopefully we have shown you a little bit more than what you already knew about FABMs, and that you might be interested. If you're interested to join FAAFP, I know Marguerite would love to have you. And so I will conclude with that, with the resources page. So thank you.